daily VMRs. Very happy and we're very excited to see you here today on another of our virtual morning reports. Today, we'll be hearing an interesting case from our very dear member, Mark, who will be joining us today. This case will be co-discussed by me as well as Dr. Ravi and Diaz as well. And we're very excited to learn more from Mark. So Mark, if you'd like to introduce yourself to the audience.
Hey everyone, I'm Mark. I'm a third-year resident at UPenn and one of the CP Solvers Academy members. I'm really excited to present this case to you all.
And Diaz and Dr. Ravi, if you'd like also to introduce yourselves to the audience.
Oh, sure, Ibrahim. Go ahead.
I was not expecting to be discussing, but thank you so much.
Oh, I guess you can be our backup, I guess. Yeah, you and Ibrahim and... There we go.
But hello, everyone. I'm Jazz from Mexico.
Hi, and I'm Ravi from Baltimore. Welcome, Roddy.
Okay, so I'm not sure who would be scribing today, but if you could please share your screen so we can take on this amazing case from Mark. Okay, thank you, Dub. So Mark, whenever you're ready, we're all ready.
Awesome. So I'm going to present this case in a very authentic manner, kind of exactly how it was presented to me. So thank you. So I was in the ICU. I recently spent a lot of time in the ICU, and it's probably like 12 hours into my shift, hanging out with my wonderful intern, Christine. And the charge nurse comes in and says, hey, a patient is getting intubated downstairs and they're coming to us. So the chief complaint is progressive dyspnea and hypoxemia over the past 2 weeks. And that's the first aliquot.
Okay. I think it's a familiar one with all of us in here. So Yaz, would you like to go first?
Of course. I would definitely want to hear you first, but now that I got the mic, I would definitely tackle the hypoxemia, because if it's progressive for the past 2 weeks, I would like to see if this patient has been having any mental status, altered mental status, or something affecting his respiratory center. That's what it's given me. Maybe a stroke, maybe a hemorrhage, something, but that would be more on the acute onset. So for me, when I hear a progressive state of hypoxemia, not only the dyspnea, I would think it is something in the respiratory center. What do you think, Ibrahim?
Fully agree with you, especially that you're focused mostly on the hypoxemia and not on the dyspnea. If we were focusing on the dyspnea, I'd probably think about it in an acute versus a subacute versus a chronic differential. In the acute differential, I'd be focusing more on the cardiovascular as well as the respiratory system. And I'd focus obviously on the high yield things. So for example, when it comes to the cardiovascular system, I wouldn't rule out acute myocardial infarction or heart failure or tamponade. And then in the respiratory system, I would think about bronchospasm, PE, pneumothorax. Those would be things that would be in my acute differential. However, for such a subacute or a chronic presentation, I feel that most likely the HPI would guide us towards a differential diagnosis for this case. We haven't heard from Dr. Ravi yet. So Ravi, would you like to expand on what Tiaz has already mentioned?
Sure, absolutely. You can call me Ravi. So I think it's very exciting, the narrative that Mark has set here with, you have this patient that's coming to the ICU and needs urgent intubation. So right off the bat, this patient has some respiratory compromise that needs intubation and mechanical ventilation. So we haven't had any more data as far as, is this an acute flare-up of maybe an underlying condition, like you mentioned. Maybe this is a acute on chronic condition. Maybe there's an underlying condition like asthma, COPD. And we don't even have the age, so we don't know if there's somebody that's maybe a senior and has pre-existing lung disease. But I'm very worried this patient is very, very ill and needs urgent intubation. Is there a issue with going from the upper respiratory tract to the lower respiratory tract? Is there something may be happening, like Yazid mentioned, the mental status, and the patient can't protect their airway. Next thing I would think about, is there something maybe obstructing the airway? Then going down to the lungs, is there something that may be within the lung or maybe compressing outside the lung, maybe like an effusion or bilateral effusion? And then you also have to worry about neuromuscular weakness as well, so the diaphragm, intercostal muscles, and so on. And then you also have to think about, for 2 weeks, was this patient breathing hard and very difficult? Was there some sort of mechanism that was causing this? And then they just got tired. So you would expect an ABG probably that was showing glaringly abnormal values, maybe a massively elevated CO2 due to respiratory muscle weakness, or central, like Yazid very eloquently spelled out, maybe a central respiratory issue. Or there could be maybe something else that's adding fuel to the fire, but we'll get that from the next aliquot from Mark. Back to you, Mark.
Awesome, wonderful discussion. So I'll give you guys some of the background data in this, and how this patient got here. This story kind of really started like 9 months prior to admission. So he actually presented to a local ED 9 months prior to ICU admission for lower back pain and right upper chest pain. He was found to have a white count 5.5 with 40% blast, a hemoglobin of 11, platelets in the 60s, and peripheral flow was consistent with AML. And his genetics were sent at that time 9 months ago, and he had a FLT3 mutation, an ITD mutation, an IDH2 mutation, and an MPM1 mutation. And he actually received 5 cycles of venetoclax and azacitidine, with the last cycle being 1 month prior to admission. And he had a few repeat bone marrow biopsies that showed no residual disease. And really just given these high-risk mutations, the standard of care for a patient with these high-risk mutations would be this, 5 cycles of venetoclax azacitidine, and then allogenic stem cell transplant. So this patient was admitted for a planned admission for an allogenic stem cell transplant. And the patient received his transplant, and then he was started on tacrolimus, mycophenolate, and prophylactic antimicrobials, which I'll go over. And then really 3 to 4 weeks after his transplant, so he's hospitalized this entire time, he developed dyspnea, cough, and hypoxemia. And I'll just give some context over these patients that come in for stem cell transplants. They usually have prolonged hospital course, mainly just waiting for count recovery. So, he was doing okay when those 3 to 4 weeks after transplant, kind of just awaiting his counts to recover. But then he developed dyspnea, cough, hypoxemia. And then 3 to 4 weeks, when these symptoms started, he got a CT scan, which showed diffuse bilateral ground glass opacities and some scattered consolidations. So given he was so immunosuppressed, the floor team started him on meropenem, and he completed a 7-day course of meropenem. But really, he had like progressive hypoxemia, going from nasal cannula to high flow nasal cannula. And he had a repeat CT chest 8 days later after that first CT that showed really just worsening of these bilateral ground glass opacities and some interstitial edema. And on the floor, he also developed altered mental status, agitation. He required, haloperidol, olanzapine, dexmedetomidine. And then he also developed an oliguric AKI and some epistaxis. The epistaxis was thought to do in the setting of his thrombocytopenia. And he really it's very typical for patients like this, for after they get a myeloablative stem cell transplant, to receive many blood transfusions. So he did receive many platelet and blood transfusions during his course, but that wasn't really atypical. And then really 12 days after the first onset of symptoms and hypoxemia, his hypoxemia worsened and he was intubated and admitted to us in the NICU. And just quickly about his past medical history, really besides the AML, he had a branch retinal artery occlusion and a central retinal vein occlusion 4 months prior to admission. He had hypertension and pseudo-gout and some of the prophylactic meds he was on. So all these patients get a prophylactic antimicrobial. So before he came in for admission, he was on prophylactic acyclovir, in addition to prophylactic levofloxacin. And then after they get the transplant, they get put on prophylactic caspofungin as well, and then prophylactic PO vancomycin for C. diff prophylaxis. He was also on famotidine, gabapentin, rosuvastatin. No known drug allergies. Really surgeries in the past really were just an arthrocentesis to confirm pseudogout and the bone marrow biopsies. no family history of cancers or any lung disease. And then for his social history, he quit smoking in 2005, was about a pack per day for quite a long time. We're not unsure of the exact amount of years, but like I said, he quit many years ago. He drank about 1 alcoholic beverage per week, no drug use. He was in the Navy, and after his time in the Navy, he worked in transportation and trucking, and then was an accountant. And he, prior to mission, he was retired and lived with his wife in central Pennsylvania. And I should say, during this course, like this, the 2 weeks where his dyspnea and hypoxemia were worsening, he was having intermittent fevers as well. And he was febrile on admission to the ICU. And that's the end of this aliquot.
Thank you, Mark, for sharing that with us. I think it added a lot of complexity to the case, but it also added other dimensions that we could tackle. So it seems at this point that this is a patient who had AML and then received courses of chemotherapy, and then eventually also had the stem cell transplant. And following the stem cell transplant, it seems that these symptoms of the dyspnea and the cough had started. The chemotherapy, to be honest, when I think about it, in such a pulmonary component, I think primarily of interstitial lung disease. And then with the stem cell transplant, I think of engraftment syndrome, as well as diffuse alveolar hemorrhage. But this patient presentation does not seem to be typical for either of these. So I think Ravi, probably, or Yaz would help us lead the way in here. So go ahead.
Yeah, I just want to kind of jump in. There a lot of great data given by Mark here, and just so really well presented. So just trying to follow the history of the patient, but in my mind, to sort of simplify the process, because there's so much going on, it's just a maelstrom of sequence of events here. But I'm thinking, okay, the lung is the center of attention here. This patient needed urgent intubation. So what could devastatingly insult the lungs? There was also findings in the lungs, so something is brewing within the lungs. There's no history of a background of a past respiratory condition here. So we have to go with something, an acute insult to the lungs here. So like Ibrahim had mentioned, the background of the AML, so the bone marrow, and then also the lung, and what could transpire between both of them. And then you got this third area coming in, which is the chemotherapeutic agents and the stem cell and so on. So we kind of have to connect the dots, and that might actually lead us to a sort of a differential of what may be impacting the lungs. Again, everything has to lead to the lungs. I'm just gonna leave maybe a thought to Yasmin. I think she has some ideas, but just I'm gonna say, okay, probably taco trolley comes to mind when you get infusions, but it usually happens right immediately surrounding the transfusions that this patient gets. Now with the AML, I'll leave that to Yasmin to see what she can come up with, and then I'll jump in again, or Ibrahim if something comes up. But Yasmin, take it away.
Yeah, thank you so much. After listening, this patient had AML and started having now, and we know he had dyspnea and hypoxemia. Some things that come to mind, and as chat brilliantly put up also, is that this patient could have first an infection, bacterial, viral, fungal infections in the lung. We could have a pulmonary, there can be like in the Venn diagram, pulmonary embolism for prolonged bed rest. If this patient has had a long time of treatment, which is like 9 months, I'm guessing. And also patients with leukemia and hypoxemia, the DDX should include pulmonary edema, volume overload, chemotherapy-induced toxicity in lungs. And there is another subset of patients that when we're thinking about oncologic emergencies, we shouldn't put away, which is the leukostasis that results in VQ mismatch. And this is basically the oncologic emergency. And for that, I have in my step 1 times of studying, I remember that I found this diagram. Like if your patient is hypoxemic, we have to look at the alveolar arterial gradient, oxygen gradient. And if it's elevated, you have to think, is the hypoxemia corrected 100% by oxygen? If it is corrected, you have to think, well, this is a big Q mismatch, or there is a diffusion limitation. If my hypoxemia is not corrected, then I have a shunt. Now, if my alveolar arterial oxygen gradient is not elevated, sorry, you have to think, is my saturation of CO2 elevated? If it is hypoventilation. If it's not, you have to think about the PiO2. I forgot what it meant in English. But basically, that's you can grab the pulmonary function of your patient, all this, calculate the arterial alveolar gradient, and that's how you kind of have an idea of what is going with those lungs, what's going on. Because we know that this patient has leukemia, my first thought will see if this patient has PQ mismatch. That will be my approach.
A great breakdown of the pathophysiology of respiratory insufficiency there, Yasmin. Yeah, VQ mismatch probably is the most common cause of hypoxemia. In this patient, what's interesting, if you follow the sequence of events, like patient transition from nasal cannula to high flow, and then also so much data here to look through. So nasal cannula to high flow, and then eventually was intubated. So the oxygen requirements were escalating. So this condition initially presented with maybe a mild AA gradient, and they got to the point where the patient's oxygenation was significantly impaired, and we'll wait for the laboratory data to give us at least, or we'll have a ABG that we can then decipher to see how significant this AA gradient was. But thinking about what benefit did the patient get with high flow nasal cannula? So nasal cannula will give you up to about 6 liters of oxygen, and beyond that, probably 4 to 6 liters. Beyond that, it really doesn't offer much. Then you have to step up to maybe a non-rebreather, where you probably get 20 to 40 liters of oxygen. And then you also don't breathe in carbon dioxide because you ventilate from a bag. So that gets washed out with a one-way valve. But then when you move to high flow nasal cannula, the game changes. The high flow nasal cannula allows you to have a little bit of PEEP, about 3 to 5 centimeters of water, also decreases dead space ventilation, and also you can significantly give 100% FiO2, so up to 60 liters of oxygen per minute. So it's a massive amount of oxygen. This patient's AA gradient is going to be significantly impacted. And then you want to calculate the PiO2, FiO2 gradient to see where this patient lies on that spectrum of ARDS possibly. So I can just envision this patient's AA gradient is just significantly deteriorating, and what's really impacting that is like VQ mismatch, like you mentioned, what's in the lung. So is the alveolar filled with something? And this ground glass and interstitial edema, if we track back, that's why I kind of wanted to leave it for Yasmin to decipher the infectious category. Yes, we talked about pulmonary edema and all these other things, but yeah, this patient having AML is significantly, has all cell lines potentially impacted. So you can think about bruising, bleeding, petechiae. You could even have thrombolysis and thrombosis. APML is a subsegment of AML, and this patient could go into a DIC kind of process. But again, the patient is sick, so something we may have to keep in the back of our minds. And then also we have to think about immunocompromised status when you have AML as well. So in addition to all the medications that Ibrahim had mentioned, so there's still a lot, and I really need to figure out the interplay, like what is impacting the lung? Is it what's going on in the bone marrow? Is it something external, which is all the medications that Mark had mentioned that this patient was getting, or is it just maybe basically an infection? So at this point, I'm still kind of wondering, and we'll see what the next aliquot brings. Back to you, Mark.
Awesome. So I'll give the physical exam and some basic labs, and then a few of the advanced labs as well. So on physical exam, when I met him in the ICU, his temperature was 100.7. His heart rate was 110. His blood pressure was 115/73. He was saturating about 95%, mechanically ventilated with an FiO2 of 100%. and a PEEP of 8. Generally, he was, ill-appearing, intubated, sedated. He was also paralyzed as well. And this was to promote vent synchrony. And, that's one of the managements of kind of severe ARDS, because he wasn't very synchronous with the ventilator. On HENT exam, nothing really notable. He did have some, you did see the dry blood in his nose and a little bit in his mouth as well. His neck exam, nothing notable. His cardiac exam, just tachycardic. I didn't appreciate any murmurs. Pulmonary exam, he had diffuse inspiratory crackles. And then on his abdominal exam, his belly was soft, really non-distended. His extremities, he was warm and well perfused. He had a right pick in place from previous chemotherapy. His skin, he did have an erythematous, like macular papular rash, I would say, on his upper chest and left upper extremity, and really couldn't assess neurological status given he was intubated, sedated, and paralyzed. For his labs, so his white count was 13.3 with a predominant neutrophilia. His hemoglobin was 7.1. His platelet count was 15. For his BMP, his sodium was 132. His potassium was 4.2. His chloride was 100. His bicarb was 16. His BUN was 118. His creatinine was 4.8. And NGAP is 16. His glucose was 185. His calcium was 8.4. Magnesium was 2.9. And his phos was 5.5. His liver function test, notable for an albumin of 2.9 and a total protein of 5.9. A total bili of 3.3 and an indirect bili of 1.5. An AST of 67, an ALT of 28, and an ALK phos of 94. He had a PT and INR and PTT that were normal. He had an LDH, which was 535, a haptoglobin, which was less than 30, fibrinogen, which was normal, a UA with large blood, mild proteinuria, and no pyuria. And then I'll say the infectious studies that he had on the floor. So when he first developed hypoxemia and dyspnea, they did a broad infectious workup, given his profound immunosuppression. And his aspergillus antigen was negative, beta-D-glucan was negative, MRSA-NAIRS was negative, urine Legionella was negative, EBV DNA negative, CMV DNA negative. They got a few repeat beta-D-glucans, which were negative. He got a respiratory viral panel that was negative, strep pneumo urine antigen, which was negative, a Strongy antibody, which was negative. And then he also had a TTE, which really was unremarkable. And that's the end of this outline.
I guess we'll swing it to Yasmin to start off. You want to take the physical exam, or?
Of course, of course. Now, as soon as I listen to dry blood in nose and mouth and trying to link it to a patient that has ground glass opacities, that has, in a patient with leukemia, in a patient that has developed hypoxemia, I am situating myself in the alveoli. What if this could be diffuse alveolar hemorrhage, and what could be causing it? The thing is, with diffuse alveolar hemorrhage, there are so many, like, it's a broad diagnosis. And now I'm also seeing that he has low hemoglobin and low platelets, but this very well could be caused by leukemia and as well as, like, I started thinking maybe a bleeding disorder, but his PT and PTT are normal. Then if the only problem here is the platelets, now with this specific presentation in the physical exam, I'm thinking there is something in the platelets that is causing me to bleed. Not really a quality, but the quantitative issue. That would be that's what I'm thinking. And now I was trying to not like thinking on infectious disease, but I see that they had everything negative. So my differential diagnosis was destroyed in a second. But that's now my first place would be the diffuse alveolar hemorrhage or something going inside of the lungs. What do you think?
Ibrahim, you want to take a stab?
Yeah, I just wanted to ask Mark a question because I think that this will be actually the center of the case. If the patient already received the transplant, or were they waiting for the transplant when their symptoms had started?
So they got the transplant essentially the second day they were admitted, and symptoms started about 2 weeks after they received the transplant.
To be honest, the thing that I was thinking about, basically after hearing about the physical exam of this patient and the fact that they had a rash, is that they might have had some kind of chronic rejection going on within the process. Maybe this is not the typical presentation of graft versus host disease, especially that we haven't heard that this patient had any GI symptoms yet. But because of the pulmonary symptoms, I'm also thinking about bronchiolitis obliterans. This is primarily because of the CT findings. So this patient initially had unremarkable CT findings, and then as time went on, it seemed that the ground glass opacities became worse. And so I'm thinking about that. And now regarding the CBC itself, now this is a patient who has leukemia. So I'm not really worried about the platelets, mainly because they'd already received multiple therapy regimens, and we already know that they have an underlying disease that's affecting their bone marrow. So this is my first differential, at least for the time being. And then one thing I also noticed was that this patient had a low haptoglobin, and then they also had anemia. So I'm also wondering, and then there was also elevated total bilirubin. I'm also wondering if there's some kind of autoimmune hemolytic anemia component also going on for this patient. But yeah, back to you, Ravi.
Oh, thank you, Yasmin Ibrahim. There's so much going on in this case, and even while listening to you, I'm trying to piece together the sequence of events to really make sense of what's going on here. So there's so many things you can latch onto and really try and tease out maybe a cause, like Yasmin had mentioned, the dry blood in the nose and mouth, and then some of the labs maybe cluing into a hematological lung association, maybe diffuse alveolar hemorrhage. So that definitely is a great thought, I would think so. And then Ibrahim is also mentioning about back to the AML and the stem cell transplant. Could that be factoring into this? So again, there's a lot more brewing here, but yeah, if I just go into the lab. So first of all, yes, there's something in the lungs. Definitely, we know the diffuse inspiratory crackles could be anything. Maybe if you imagine an alveolus, is it the alveolus or in abnormality in surfactant and maybe surface forces or intrinsic alveolar forces as well. So if there's something, if you imagine something within the alveolus, the pressure will be greater to collapse at the end of end of expiration. So that's where the PEEP would be necessary, and hence ventilation. If surfactant is affected, maybe something externally, even pancreatitis could actually take out, the lipase could take out surfactant that could also overcome the forces at the end of expiration. So I would guess these crackles aren't your routine fibrous crackles. There may be something within the lung, blood, pus, water, but here more blood, maybe pus. There is a twinge of maybe an infection here, but it's hard to tell. This isn't your usual normal competent, a patient with a normal competent immune system here. We're dealing with a patient with immunodeficiency. So it's difficult to say the temperature, the fever is low grade, the white count is slightly up, but this could be all part and parcel of their AML status post stem cell transplant. And then just looking at the labs, probably everybody's thinking there's a hemolytic reaction happening here. So what gives us a signal for hemolysis here? First of all, haptoglobin being low, but we also have to consider if haptoglobin being a protein, is it made in sufficient quantities? And if I remember, it's made in the liver. So if there's any hint of liver insufficiency, this may not reflect in a proper level of haptoglobin. But putting it all together with the LDH probably is from a hematological or etiology rather than any sort of injury to a solid organ like kidney, liver, and so on, or heart. So LDH being high, haptoglobin being low, and then of course the bilirubin. So we want to look for more of an indirect bili, but here the total bilirubin is high, so direct bili is higher. Or no, actually a little lower than the indirect bili here. So this to me means that there's something going on with the blood. And again, we've had cases where this could be, is it an autoimmune hemolytic anemia? So we do need a Coombs test for this, which hopefully Mark has, if the Coombs is negative. But you can have a autoimmune hemolytic anemia, which could be warm, cold, or it could be a transfusion reaction. But guess what? This patient had likely transfusions for all the cytopenias and abnormalities. So maybe this could be part of that transfusion reaction that you may get. There's a delayed graft versus host transfusion reaction, which can happen months after. So it doesn't have to be within the recent vicinity of a transfusion. And then we have to think about, if the Coombs test is negative, is this something along the lines of TTP, HUS? Is this maybe DIC? But what sort of takes DIC out of contention would be the normal PT and PTT. We also would need a fibrinogen in this case. So I kind of would look at those. Looking as far as the infectious workup, so beta-D-glucan is negative. So it's pretty good, I guess, for PJP, but it doesn't test for those fungi that don't have cell walls. If I remember, Cryptococcus mucor may not be picked up by it. But aspergillosis definitely is picked up by it as well. And we don't have a galactomannan. That would also be a test to look for aspergillosis. And then the rest, MRSA, Legionella, all negative. Again, Legionella, there's only the urine test for one serotype, so you still could have Legionella in this patient. But at this point, I would look for an answer to this hemolytic reaction. Is this the center and focus of this case, or is this just like a bystander? Is this something that's a downstream effect of the primary process? So there's some disturbance in maybe the kidney here as well. The AST is higher than the ALT. That also supports hemolysis. But again, is this hemolysis significant, or is it just part of this whole bone marrow issue? Again, B12 deficiency. I think there was a recent VMR of B12 deficiency. You can get intramedullary hemolysis. So hemolysis could happen at any stage. But is this what we should really be following? Not sure at this point, but let's see what Mark has in store for us. Before we move on, Yasmin, Ibrahim, anything spark your interest there?
Yeah, I'm just going to. Oh, go ahead, friend. Go ahead.
Go ahead.
Oh,
It's fine.
Thank you. I just wanted to just say it out loud. Another thing that come to my mind was the TRALI, or the acute. It's transfusion related acute lung injury. Although the onset is not. It's over like 2 weeks. This is a more acute presentation. Like it has to be a more acute presentation to be TRALI. I'm thinking about this because we have leukopenia. We have not leukopenia, thrombocytopenia. We have multiple transfusions. We have a diffuse bilateral gram-positive. So that is like also part of my diagnosis, differential diagnosis. But I would definitely love to hear what Ibrahim has to say.
Yeah, I just wanted to comment on the fact that this patient had the localized rash. I feel that, like we're discussing diffuse systemic diseases. I'm not really sure how those would relate to the fact that they had the rash only on their chest, which makes me more excited honestly to learn more about the diagnosis as we're going to go on with this case. But I feel one thing that we're often taught about the localized rash is the fat embolism syndrome, but then that presents usually with a petechial rash. But I feel if this was a petechial rash, despite the fact that this patient does not have neurologic symptoms, they still have the bicytopenia that you would typically find. They still have the risk factor, the transplant that they had. But yeah, that's just a thought that popped in my mind, and I thought I could probably share it.
Oh, Ibrahim, that's a great thought. You just triggered a thought in my mind. I totally neglected the rash. So that's why I love these combined discussions, because we can just sort of bounce ideas off each other, because everybody is looking at this at their own, I guess, angle. But I completely kind of neglected this. But one thing I have found very interesting with the skin, it can reflect what's going on internally. But in this case, there are a couple of skin rashes that can reflect shock states or severe critical states like sepsis. So purpura fulminans can be a finding on the skin with severe sepsis. Livido reticularis, usually in the lower extremities, and like you mentioned correctly, that could happen with air embolisms, I guess, fat embolism, petechiae more with the fat embolism, but a couple of rashes with critical illness that you have to think about. I think those three I think about. But at this point, yeah, let's swing it back to Mark and see what else he has in store for us.
You guys are on the right path. So as requested, so he got a peripheral blood smear that showed about 5 schistocytes per high power field. He got a Coombs test, which was negative. And I'll just say that our aspergillus antigen is the same thing as galactomannan in our lab. So his galactomannan / aspergillus was negative. And then he just continued to have refractory hypoxemia. His P to F ratio, as mentioned before, was consistently less than 100, kind of signifying severe ARDS. And then he started to have bloody output from his endotracheal tube. So a bronchoscopy was performed. So the first thing I noticed on the bronchoscopy is they did serial lavages, and they became progressively more bloody on serial lavages. And some studies from the BAL, there was 1,719 WBCs. There were 17,562 RBCs. The diff was 40% neutrophils, 60% lymphocytes. He had a lot of infectious studies off of that. So he had a respiratory viral panel off of the BAL, which was negative. He had a routine respiratory culture that was negative, an anaerobic culture that was negative, a fungal culture that was negative, an AFB culture that was negative, an aspergillus antigen or galactomannan that was negative, an histo antigen that was negative, a PJP PCR and DFA, which were both negative, and a CMV that was also negative. Just want to make sure I got all the infectious studies because he had many. A Legionella also on the BAL that was negative. And then there was other studies sent when the bloody output from the endotracheal tube. So he had an ANA, which was negative. He had an ANCA, which was negative. He had an RF that was negative. He had a cryo that was negative. And then he had an anti-GBM that was also negative. And the next aliquot will reveal the diagnosis.
I'm going to have Yasmin. She mentioned something in the chat, so I know she's eager to weigh in on this finding. Take it away, Yasmin.
Oh my God. First, I want to say that with every single like Legionella negative, anti-GBM all negative, and ANCA, like I was thinking, okay, first I thought diffuse alveolar hemorrhage. This can be caused by a lot of infections, by a lot of like issues like rheumatologic, hematologic. Right now, I'm more in the hematologic area, seeing these schistocytes and seeing low platelets. And with all of these negative antibodies, I'm thinking this person is having a diffuse alveolar hemorrhage due to issues in the platelets being or a TTP or ITP. That would be my first, like trying to put everything into a Venn diagram. That is my first diagnosis. And of course, if we see that this patient has a progressive dyspnea and keeps bleeding and has this particularity of this leukemia, that is my first thought. What do you think? I am really puzzled as per with the case, Dr. Mark's case.
Ibrahim, what do you think?
Yeah, to be honest, from my side, I don't think that I have something else to add to what Yaz had already mentioned. I think my biggest question right now is to know if this is something that is localized to the respiratory system, or if this is something systemic and is manifesting with hemorrhage in the pulmonary system, which is resulting in this patient's hypoxemia. So yeah, nothing from my side.
That's a great thought, Ibrahim. Yeah, just sort of moving from what Yasmin had mentioned. Yeah, TTP she mentioned, which just going through the way you think about hemolysis, and then this panel labs, that definitely comes front and center, like as a possible cause. Here, platelets are very low, as we tend to know. With TTP, platelets are usually lower than 30,000. And we haven't had a Adams T13 yet, so maybe Mark is holding that close to his chest and will reveal that, but that will definitely help. We can calculate the plasmic score. I don't have MedCalc in front of me, but that would be helpful to see. And then I also have to wonder, wait, what other conditions can cause, if say the Adams T13 is negative, what else could cause massive hemolysis? You have to start thinking about external forces and then internal RBC forces. So external, you could have anything from severe hypertension causing that, hypertensive emergency, external forces like valvulopathies, doing a sort of a fruit ninja and cutting up RBCs, or even a valve cutting up like a blender. But then we don't have that here. Even autoimmune phenomena like scleroderma renal crisis can cause a MAHA, but then you also have to have a pre-established history of scleroderma. And we do have the kidney failure here. We don't have the high blood pressure also. And then intrinsic RBC issues, you have to think about infections. Maybe leishmaniasis can do that. Also, you can have malaria. You can have what else could babesiosis, and one more that's kind of escaping me. Bartonella could do it as well. So those sort of things. But again, I'm not really getting the strong sense from this case that maybe something like that is happening. Is this TTP? But then again, what flipped the switch on causing TTP? I'm not sure, but there's a lot that we could pretty much finger point and blame to maybe cause this, if this is a case of TTP. The white cells, sort of everything's perturbed in this. So there's a lot of inflammation that's downstream from what's going on. So the white cell being high, and I can see the really significant infectious disease workup that Mark and his team went through. It's just very exhaustive, but they're trying to find out if there's an infection causing this presentation. I really applaud you for that. This patient was really well taken care of. Once they were intubated, you had time to then work through and think about what is causing this patient's condition. So I'm just astounded by the amount of data that you're presenting here. But let's swing it back to Mark and see if he has a Adams T13 or any other data that can help us.
Yeah, so I'll actually say this patient has two diagnoses. And the main one is actually clinical. So I'll say the first one is the Adams TS13 was negative. I did not say that the patient did have a pretty high TAC level a few days in a row when he was on the floor. So he was thought to have TAC-induced TTP, or a thrombotic microangiopathy. But given his GGOs, his rash, his fever, his absence of infectious etiologies, and given the timing of his hypoxemia, 2 to 3 weeks after bone marrow transplant, and just kind of at a similar time that he engrafted and his neutrophils count started to rise, he was diagnosed with peri-engraftment respiratory distress syndrome, or PERDS. And he was started on steroids, but unfortunately his disease just progressed very rapidly, and he passed in the ICU 2 weeks later. So yeah, the final diagnosis is peri-engraftment respiratory distress syndrome and TTP from TAC.
Incredible, Mark. It's very sad that in spite of all this and all the efforts that your team put in, the patient passed away. So we appreciate the patient and for allowing us to also learn from this, from their case and their hospital course at your institution. And This PERDS, you could sort of, I think at the beginning we did think about all the measures that were implemented can have a multitude of different side effects, but PERDS I was not aware of, so something else to put on my list of topics to read. But I really appreciate you bring this case, a very complex case, and this is a real life case that you may encounter in the ICU, and definitely having some knowledge in transplant medicine, stem cell transplant as well, that does help with being familiar with this kind of a process. But TTP, I didn't know tacrolimus was called TTP, but it was kind of evident when you go through hemolytic anemias that this definitely we did need to consider TTP. Yasmin, Ibrahim, any reflections?
Yeah, thank you, Mark, for this case. I think it was a humbling case. And I personally have a lot to read on PERT. I think we mentioned PERT in the beginning. However, something that actually made it fall out of my mind is the lack of fever as well as the lack of GI symptoms. But it's interesting to learn about this diagnosis and see an actual patient who actually had to go through all of this. So sorry to their family, of course, Yani. But I hope now, they pass this teaching to us, and hopefully we're going to pass it in the future to future patients. So thank you, Mark.
Yeah, I completely agree with Ibrahim. This PERDS was definitely not on my differential diagnosis. I was just thinking of Trali and Taco and also because that's what I know, that like this has helped me to find out the knowledge gap. So I'm pretty sure I'll be reading more about PERDS and like how even we have Adams 13 negative, we still can have TTP. And that's something that I'm pretty sure that whenever we see a patient like this, we will be able to get a diagnosis quicker, maybe. And of course, sorry for the family and sorry for the loss. But thank you so much for these teachings.
And we should move on to teaching points.
Hi, yes, I'm sorry. I just having some connection problem. Thank you so much for this amazing case, Mark, and thank you, Yas, Dr. Ravi, and Ibrahim too for discussing it. So we start off with a patient with dyspnea and hypoxemia, and we started talking about the approach of hypoxemia, basically if there's any associated condition, especially respiratory, in this patient with a past medical history of oncologic disease and hypoxemia, we should consider the AA gradient. So I'm basically asking about if the patient with the hypoxemia, if it responds to oxygen or not. So at this point, if this patient with the oxygen saturation, if respond with minimal oxygen, we think about, yes, there is a normal AA gradient. But if it doesn't respond, we think about it's an increased AA gradient. And we think about maybe there's a shunt. So in this case, if it's increased AA gradient, we think about maybe it's a problem with the vessel or alveolar. We think about maybe possibility of PE, possibility of a pulmonary arteriovenous malformation, or some pus or air or liquid in the pleural space. So, and then we move on to the approach to dyspnea, which is we think about the timeline is important if it's acute, subacute, or chronic. And we divided the dyspnea into different buckets, cardiovascular causes such as tamponade, acute coronary syndrome, or the pulmonary bucket. We think about PE, pulmonary hypertension, and if it's a problem with the airway, we think about asthma, COPD, and other causes can be due to neuromuscular, such as myasthenia gravis, ALS, or Guillain-Barré. And in this case of the patient, it's very, very important to consider if there's a need for mechanical ventilation and rule out possible obstruction of the airway. And then we moved on about to think about the possibility of this patient with under chemotherapy, if there's any insult to the lungs. So we think about possible tackle versus trolley, and then we talk about trolley as acute onset of hypoxemia and dyspnea with the bilateral infiltrate, leukopenia, hypotension, tachycardia, thrombocytopenia, and the multiple previous transfusion that this patient had. And Jazz also mentioned about the acute diffuse alveolar hemorrhage, which is also present with hypoxemia, dyspnea, chest pain, hemoptysis, and fever. And then when we receive the labs, we see there's a thrombocytopenia, and we think about maybe there's a problem in the RBCs, and we think about maybe the possible causes such as MAHA. So within MAHA, we think about TTP or DIC, and we consider to do the peripheral blood smear, which is the person of schistocyte, also revealed there's a hemolysis. And we talk about the RBC, if there's a problem with the membrane, is it intrinsic causes versus extrinsic causes. And also the approach to the thrombocytopenia. With the rash, we think about DIC, purpura fulminant, and TTP. And in this case, the patient turned out to be a case of TTP caused by the use of tacrolimus, and we learned as well a new diagnosis that I am not very familiar with, and that would be great to add it to our next lecture. Thank you so much, everyone.
Thank you, Yi. That was fascinating. That was just amazing. I can imagine you, once you're an intern and you're just like so eloquently talking about hemolytic anemias, you'll definitely astound your team. So brilliant teaching points, or delivery of teaching points there. Appreciate it. I think Mark has a few maybe points about PERDs, if you can sort of educate us about it.
Yeah, thank you, everyone. This was a lot of fun meeting. That was a great recap. The other thing I was going to add is this diagnosis was totally not on my radar as well. We do see a decent amount of oncology at Penn. However, the bone marrow transplant patients typically go to our onc ICU, but our oncology ICU was actually full, so they came into the medical ICU. So, I was very nervous about this case because it's just not I don't see this too often in the ICU, but I think Ravi put a really good figure and schema in the group chat, but I think which is kind of the center of this case. And essentially, you kind of think of these patients in 3 phases. As phase 1 as the pre-engraftment period from like 0 to 30 days from transplant, phase 2 around 30 to 100 days, and then phase 3, the late phase, greater than 100 days after transplant. And each of those phases, there's different complications. The pre-engraftment period can be like, even from 0 to 14 days, like in our patient. And essentially, right at that point, when the neutrophils start to engraft in the patient, the neutrophils can unfortunately attack all organ systems. So a common one which they attack is the lungs. So it's really a lot of neutrophilic inflammation that happens in the lungs, which causes PERDs. And it really causes fever, BAH, rash. I didn't read too much about GI manifestations. I wonder if that's the one difference between like your classic graft versus host disease and PERDs. It seems like it's very centered around the lung. But yeah, as soon as you see those neutrophils starting to take off, essentially after about 5 days of them increasing, make sure PERDs is on your radar. But every time you see these patients, just think of phase 1 pre-engraftment, phase 2 post-engraftment, and then phase 3 late phase. And there's different infectious complications at each phase, kind of highlighting kind of the first stage when you're profoundly neutropenic. So you get in-hospital complications like gram-negative bacteria, gram-positive bacteria, aspergillus. And then as you move to phase 2 and phase 3, it kind of shifts to more, viral infections, chronic bacterial infections like, nocardia. So I'll send a really great article that highlights these pulmonary complications of bone marrow transplant in our group chat. But yeah, thanks everyone.
Great, thank you for that. That absolutely does help us trying to approach a problem like this in the future, hopefully. So that 3-pronged approach, definitely will look for that schema and sort of mull on it to at least help us in encountering a case like this again in the near future. So thank you, everybody. Have a great rest of your afternoon. See you tomorrow. Bye. Thank you, Yasmin. Thank you, Ibrahim. Pleasure to discuss with you as well.